This is a technique guide video for imaging of abductor tendon tears using MRI. Sequences utilized include T2 fat saturation coronal images. This is good for visualizing the insertion of the tendons onto the greater trochanter. It allows evaluation of the undersurface of these tendons for possible tears, and it allows measuring the tendon length from the proximal insertion on the greater troch to the musculotendinous junction, which when greater than 2 centimeters may suggest a partial thickness tear. T2 fat saturation axial images. These are helpful for locating the tendons proximally, following them distally onto the various facet insertions of the greater troch. It's helpful in characterizing undersurface tears, as you see fluid on the undersurface of the tendon in between it and the bony insertion. It's also good for seeing TFL hypertrophy. T1 coronal images are helpful for evaluating the abductors for fat atrophy, as well as evaluating the TFL for hypertrophy, which both can happen in the chronic abductor insufficiency situation. This is an axial image proximally, where you see the medius as well as the minimus. Following this distally, again you see the medius as well as minimus. Here is an axial image showing the superior posterior facet insertion of the gluteus medius, lateral facet insertion of the gluteus medius, the bald spot between the lateral facet and the anterior facet, and the anterior facet insertion of the gluteus minimus. Moving distally on this axial image, here you can see the lateral facet insertion of the gluteus medius with no intervening fluid between the deep surface of the gluteus medius and the lateral facet trochanteric bone. Here is the TFL showing no signs of hypertrophy. This is a coronal image, approximately 1 to 2 slices posterior from the lesser trochanter, in which you can see the superior posterior facet insertion of the gluteus medius. 1 to 2 slices anterior to that, you see the lateral facet insertion of the gluteus medius, normal length from troch insertion, the musculotendinous junction less than 2 centimeters, suggesting no partial thickness tear. Anterior to that, you see the minimus insertion onto the anterior facet. This is the pathologic state, where you can see a complete disruption of the gluteus medius insertion onto the superior posterior facet. Anterior to that, complete disruption of the lateral facet insertion of the medius, as well as disruption of the proximal aspect of the insertion of the vastus lateralis. Moving anteriorly now, you can see here the vastus lateralis insertion has been disrupted from its insertion onto the vastus ridge. Again, you see the fluid on the deep surface of the gluteus medius, as well as inflammation superficial to it. On this image, the gluteus medius insertion onto the lateral facet, distance from the lateral facet insertion to the musculotendinous junction is greater than 2 centimeters, which suggests at least a partial thickness tear. On this axial image, you can see this superior posterior facet is intact. The lateral facet seems to be intact. However, there is fluid on the undersurface of the lateral facet insertion of the gluteus medius, which may suggest an undersurface tear. This is another axial image showing intact gluteus medius insertion onto the superior posterior facet, complete disruption of the medius insertion onto the lateral facet, and fluid both superficially as well as deep on the gluteus minimus insertion onto the anterior facet. Moving distally, again the minimus does not attach to the anterior facet, suggesting a complete disruption. And even more distally, the vastus lateralis insertion is also not attaching to the vastus tubercle, suggesting a vastus lateralis disruption. Note on this axial image, the TFL is hypertrophic, suggesting a chronic abductor insufficiency. Note the normal size of the TFL here as compared to the hypertrophic size of the TFL here, suggesting chronic abductor insufficiency. Note normal abductor muscle belly compared to the fat atrophy noted here in the abductor, suggesting again chronic abductor insufficiency.